Good morning, everybody. I'm Dr. Kevin Stoddart. I'm the co-chair of the Ontario Working Group on Mental Health and Adults with ASD, and very pleased to bring greetings to you this morning. This conference is the culmination of many, many months of work, and as I said at our pre-conference dinner last night, you'll recognize the conference organizers by the deep dark bags under their eyes, because their conference organizing starts at about 8:30 on a Tuesday or Thursday night, and I'm far past my prime then, but they've done an amazing job, and we look forward to a wonderful day. Dr. Weir and I are, of course, open to hearing from all of you, each one of you, as to how we can move this very, very important agenda of ASD and mental health forward in Ontario and in fact across Canada. So we welcome your input over the period of the conference today, but also as we move forward in our province. It is my great opportunity to introduce Dr. Fred Volkmar to you today. And Fred will magically appear by video conference shortly. Unfortunately, he was not able to make it today. But Dr. Volkmar is probably one of my heroes and colleagues in the field of ASD, is certainly a hero to me. He is the Irving B. Harris Professor of Child Psychiatry, Pediatrics, and Psychology at Yale University Child Study Center. He recently served for 8 years as director of the center. A graduate of the University of Illinois and Stanford, Dr. Volkmar completed residency training in adult psychiatry and then a fellowship in child psychiatry at Yale University's School of Medicine, and has been there ever since. He has dedicated his career to understanding and treating children with developmental disorders and is a leader in the field of autism research. He has served as a teacher and mentor to many trainees, some of whom are now leaders in the field of ASD. He is editor of the Journal of Autism and Developmental Disorders and a gifted clinician and teacher. His contributions have undoubtedly greatly improved the lives of children suffering with developmental disorders and their families. Please give a warm Canadian welcome to Dr. Fred Volkmar.
Good morning. Can you hear me? Good. Go figure. So first of all, I'm very sorry not to be with you in person, having spent a good portion of yesterday waiting in the airport, getting on and off the little airplane, which eventually did not fly to Toronto. And I'm very sorry because I was really looking forward to this conference. This is a very important topic and you have a very exciting day ahead. And I truly am very, very, very sorry not to be there to enjoy it with you. And finally, on possibly a lighter note, I was looking forward to being in Toronto to practice my Canadian A in case I need to move, depending on the election day. So anyway, I hope with all this, as by way of introduction, let's get going. This is a bit of a smorgasbord of a talk. I'll show you an outline in just a second. I did want to mention, for anyone who's interested, there's a whole series of lectures on YouTube and iTunes U, Apple iTunes U, iTunes University. My colleague Jane Brown and I just did one on students in high school with ASD wanting to go to college. It's going to be posted within the week. But anyway, if you're interested, it's a free resource. You have somewhat different issues in Canada than we do in the States about colleges and high schools, but there's also a lot of overlap. And the happy news, in some funny way, sort of the summary of this talk, we have an interesting new problem, which is more and more students with autism are going to college, which is great. But then they need supports. They present some challenges because of our limited awareness at multiple levels. But let me move on. So I should mention my conflicts of interest, which these days are books. And as you heard, I'm an editor of the Journal of Autism. I want to do a little bit in terms of background, say a little bit about diagnostic issues, and then talk about how we understand autism and how we think that's led to some changes in treatment and outcome. Just a little bit about economic issues, and then really the rest of it talking about what we do and don't know. And sadly, there are many areas where I'll say, it looks like there's a lot. In fact, there's very little. And there are many gaps in knowledge, and then we'll close, and I think hopefully have time for questions. And people should have these slides as a handout. And if not, please feel free to email me and I can send them to you. So some caveats getting into this. As Mark Twain said, I've seen a heap of trouble in my life and most of it never came to pass. So when I mention a little bit about what we don't know, keep in mind that conferences like the one that you're at are actually already starting to enrich the knowledge base for adolescents and adults with ASD. Also, I should say, it's always easier to say that we can predict the past than to predict the future. But we can look a little bit at where we've come from and where we want to go. And finally, to quote, I think, Benjamin Disraeli, we'll come back to this when we talk about DSM-5 in a little bit. There's three kinds of lies. There's lies, damn lies, and there's statistics. So some paradoxes and challenges. If you think about it, stepping way back when, there's my local tech supporter, and it's going fine, Mark. All right, thanks. Autism was once thought to be rare, and it's now thought to be very common. There was early confusion with schizophrenia. Childhood schizophrenia itself is now actually relatively rare. Strangely enough, just this week on Tuesday, I saw a 13-year-old boy that I think is becoming schizophrenic, and it happens probably every other year. It's a very uncommon thing, but you do see it, and it happens, but it's not autism. Although Connor emphasized developmental issues and changes over time, interestingly enough, we've put relatively less resource into following children up over time. These days, certainly in the States, most of the federally funded research is on infants and very young children. Research in the older age groups is extremely limited. The last I heard, there was one federally funded project, which was in Wisconsin at the Weissman Institute, and that was not through the National Institute of Mental Health. Then there are going to be diagnostic tensions, and we'll talk about the lumping, splitting. But a real problem for us in thinking about adolescents and adults is this problem of comorbidity. In mental retardation or intellectual disability research, for many years, people pretended once you had that label, that was it, no more. Well, of course, the reality is, as people started to look, and they started talking about diagnostic overshadowing, and with the mildly intellectually impaired people, you can do traditional psychiatric interviews, rating scales, tests, etc. The rates of psychopathology were 4 to 5-fold increased over the general population. We're coming back to revisit that in some ways with autism, and we'll have a chance to talk some about that, and I hope there's some questions. So more paradoxes. Often what we're doing is generalizing knowledge from one age group to another. This often makes very little sense. We do a lot of generalizing about interventions from school-age children and sometimes even younger children to adolescents and adults with very little information. I think Dr. McDougall's going to be talking about psychopharmacology, and one of the things I suspect he'll say is that there are very interesting variations in response to drugs depending on age, pre and post puberty. So the generalizations often make little sense, but we have to go with what we've got, and we go with drug trials, often done with older people, but you have to be very skeptical there, generalizing it back to children. So there's a lot of reasons to be skeptical about our many generalizations. Let me say a few words about diagnostic issues. So if you, again, step back historically, we started with Leo Connor's classic description. He said there were two things for autism. One was autism, living in your own world. The other was what he described as resistance to change, this whole insistence on sameness, which is kind of the flip side of the coin, but a packet of behaviors, difficulties, including stereotype mannerisms, that all were encompassed in this resistance to change. Interestingly, his observation, not surprisingly given that was Connor, had a lot of meat in it. On the one hand, he's paradoxically saying, look, these are children who don't want to play the social game. They're not interested in the social world, but they get very attentive and very upset with changes in the non-social world. And that's actually been the trigger for a lot of research, which I'm going to touch on in just a bit. Michael Rutter's 1978 synthesis of Connor's work was very influential. It had a very strong influence on DSM-3. Rutter said, you have to have social difficulties that are not just due to associated mental retardation. Language problems, now we would say language and communication problems, not just due to any associated mental retardation, and the unusual packet of odd behaviors, resistance to change, and onset early in life. By DSM-3, for the first time, first of all, there was a sea change in psychiatric diagnosis. It became atheoretical as opposed to the first two passes of DSM. It also included a number of new disorders, of which autism was one. Autism was included as infantile autism, which meant very young children with autism. And indeed, it was a kind of a description of very young children with autism. There was a category called residual autism, residual infantile autism, for people who had once had infantile autism, but no longer had infantile autism. This was a problematic issue for adults. There were attempts in DSM-3R to change this. Lorna Wang was very involved, Ed Lover. It was a much more developmentally oriented definition. People had concerns about it, however, because they thought it probably over-included, especially among the more profoundly intellectually and cognitively impaired. For DSM-4 and ICD-10, for the first time for the DSM and ICD, autism was seen as a package together. The group of us worked together to do a large international field trial. We ended up including autism as well as Asperger's, Rett's, childhood dissociative disorder, and PDD-NOS. DSM-4 and then its successor DSM-4-TR, which were around for, I guess, about 2 decades, actually, I think in many ways did a great job. There was diagnostic stability. The international system and the American system were the same. People could more or less have confidence when we were talking about autism, we were talking about the same thing. DSM-5 has a complicated package of issues associated with it. If anybody's interested, I can send you a very interesting little bibliography. There are now a couple of books on the DSM-5 process. There are some things about DSM-5 that are very good, some things that are very problematic. In terms of autism, let me just touch on 2 of the big picture issues that impacted on autism. One was the decision in DSM-5 to really rely as much as possible on information from diagnostic instruments, things like the ADI and the ADOS, in terms of coming up with a new definition. This was true across DSM-5. It has a funny aspect of the dog chasing its tail, of course, in that the instruments were originally developed to parallel the categorical criteria. So there's a funny sort of intertwined aspect. The other thing that's very problematic, to my mind, is although the data are great, you have to go take a week of training to do the ADA. You have to go take a week of training to do the ADOS. I'm not opposed to that. I think that's fantastic. They're wonderful instruments. But the problem is if an instrument like DSM is to be used generally for clinical purposes out in the community, people are not going to go off to have that kind of training. So it's an odd business. You might also suggest, as people have, that this was a cheaper way to do it, and that you might also face the fact that there's some economic aspect to DSM-5. But there were some concerns relative to adults very quickly. Now, again, I don't want to prejudge what I think of the DSM-5 system, especially for autism. We have a new system, ASD, Autism Spectrum, which is actually not a bad term at all. Should have been used in retrospect in 1980. We have a new social communication disorder, which comes out of nowhere. There's literally one study saying it's great, and that's from Sally Ozanoff. Otherwise, there's very limited data. We really don't know much about it. There are no more subtypes and no more subthreshold categories. That was another one of the overarching decisions in DSM-5. We're going to make it more scientific. Everybody's going to fit into a category. Nobody's atypical. For autism, of course, that's very problematic because we've always known, if you go back to read the first epidemiology papers, the first reviews by Eric von Bohn, he's saying strictly diagnosed autism is this. Then you start to broaden your definition, you get this. And so the problem is, as people have thought more about autism spectrum, they think about a spectrum. And so it's a funny tension. So we've got a new term, autism spectrum, which is great. The problem is we have 2 categories rather than 3. That was done based on a large factor analysis of ADI and ADOS data. I can tell you back to DSM-4, we actually factor analyzed the data as well. You could get 2, 3, or 5 factors, depending on how you set it up. It was all perfectly rational. If you did 2, you got social communication and the restricted behaviors. If you did 3, you got social, communication, and then the others bifurcated, trifurcated into a sort of mess of resistance to change, troubles with stereotype mannerisms, etc. The problem fundamentally with DSM-5, with DSM-4, we had over 2,000 ways using the DSM-4 criteria that you could get an autism diagnosis. But now we've moved to 12 combinations, 12 categories. That is a big change. And as you would think, this is going to make for some differences. We've also, for the first time, included sensory issues, which is very interesting. There was a tremendous amount of pressure, I think, to include some sensory processing issues, sensory processing disorder in DSM-5. It's sort of snuck in here. The limited data on this, we looked at sensory issues in DSM-4. It actually was not very discriminating. We didn't use it. And in fact, I think there's now some work coming out that's going to suggest when you see the sensory problems, the problems are things like not responding to the name. Yes, it's a sensory issue, but it's also something much more fundamental. So it's a very interesting package. My colleague Jamie McPartland and I reanalyzed some of the DSM-4 data, what we could find. And in point of fact, about 75% of the people who had a diagnosis of Asperger's, similar number in terms of PD&OS, and DSM-4 terms, no longer would have an ASD diagnosis. And for that matter, among the people with higher IQs who had autism, only about 75% would get a diagnosis. So in point of fact, we've paradoxically gone back to Leo Connor's autism. I'm sure this is going to be changed in DSM 5.1 or whatever it is. And you'll have to buy that book too, and the manual and the accompanying videos. But it is a problem. And to think about in retrospect, shouldn't we have a more rational way to sort of approach this whole set of issues and problems? So having struck a blow at DSM-5, let's talk a little bit about research. If you look, and this is now looking at Medline, you get different results depending on your search engines. There's a lot of reason to be skeptical, but it's at least somewhat helpful. This is now done by 5-year blocks, and we're looking at the number of publications per year. So between 1980 and 1985, there were maybe 600 publications, a little over 100 a year. If you look at this, we've seen an escalation. Last year, I think we're going to see something like 2,600 papers published. It's just exploded, which is great, except that you have to keep track of it. And that's very hard to do. The sad thing is that if you look here, this is a similar set of numbers. This is from PsycInfo, but this is looking at the numbers as they go up. The gray bars are showing total numbers of autism publications, but autism and treatment, as you can see, is a very small number. And for us, thinking about the problems of adolescents and adults, these are scarcer than hen's teeth because they're so very hard to get funded. The research overall, if you look as of February, a few weeks ago, on Medline, I got almost 26,000 papers that were keyworded to autism. If you search for autism in the title, adults, there are 462. But that's a very misleading number. For example, employment and autism, 33. Several of those are reviews. In fact, it's about 20 papers that are really research papers on employment and autism. Suicide, 31. In point of fact, there are probably 2 papers on rates of suicide and autism. Everybody else is saying we need data. Aging and autism, 11. In point of fact, there's a handful, 3 or 4 papers that are really about aging and autism that are empirical research papers. I'm not counting chapters, I'm not counting books, but empirical research studies. So it tells you what the problem is. Well, we know that research in general in autism has increased for many reasons. There's a lot of intellectual interest. There's a lot of interest in autism because it's a chance to bring the social brain, genes, behavior together. We're going to have animal models. One of the big changes over the last several decades is we have parent groups and foundations actively supporting work in autism. As money has gone in from the federal government side, people have applied for the grants. This is what we call in the States the Willie Sutton problem. I'm sure you don't have people like this in Canada. Willie Sutton was a famous bank robber in the States, and they once asked Willie why he robbed banks, and he said, because that's where the money is. Well, I think that's one of the reasons why also people see that that's where the money has gone. There's also increased media attention and a lot of interest on the internet. So why so little work on adults? Well, understandably, there's a big emphasis right now on early diagnosis and screening, and that hopefully is leading to better outcomes, and that's great. That being said, because it's a hot topic, good, but one of our problems is how do we get to adults? There are issues in terms of identifying people who have autism and intellectual disabilities. In the States, that's much more tightly regulated in terms of research. Much of the work that's been done, for example, on bullying, some of the survey stuff is done online. People don't even know the person. They're doing a rating scale or some kind of questionnaire. I'm not knocking it, I'm just saying that's what it is. And so you have to be very careful. What we really need right now are data on people who were seen as children with this good characterization, and where we can then follow them up in adults and try to make some sense out of changes over time. And that's one of the fascinating things is you can see a child. I just saw a child last Friday. We saw at 4, he was speaking, I think it was Hungarian. We had to do a nonverbal IQ test. The child was not in great shape. We saw him 3 years later. He found a good person who was working with him in school. He was looking much better. I saw him at 11. He's looking fantastic. He may go to college. Well, you see that. Now, again, you can't always predict, which is very frustrating for parents. But we're seeing more and more people do better and better, and that's a tribute to some of our early efforts in diagnosis and screening. We also know, certainly in the States, and you hopefully have different kinds of supports, the grant review process is far from perfect. There's a lot of emphasis on social issues fads. There are many challenges for treatment studies. I joke when I'm on a study section that they're easier to kill than a wounded duck in the water. Everybody's going to find something wrong with a treatment study. Oh, you didn't use my special checklist of blah, blah, blah. Or it's like treatment approaches, treatment studies are like Oriental rugs. There's always going to be some little flaw, and people are good about finding it. And so treatment studies are extremely hard to fund, and that's a real challenge because that's part of what we need for adolescents and adults. Also, I would say, and in the States, we've not done such a great job of this. We should do a better job of translating our research into the lives of children, schools, families, adolescents, and adults, and sort of make some connections, which I think now can start to be made, not just at the level of gene, brain, and behavior, but thinking about how can we think about a person's abilities and difficulties and translate that into a way to approach them to foster adult independence. Economic issues. And again, there's a nice, small, but a nice literature on this. This is a very expensive proposition. If a person with autism ends up in residential care, it costs millions of dollars over their lifetime. There have been estimates both in the US and the UK about how much we're spending on adults who need that kind of care. If anyone is interested, there's a fantastic chapter by Martin Knapp on the economic aspects of autism in the Handbook of Autism. So the nice thing is we can actually say, based on data, that if we can increase functional outcome, it has not only benefit to society and the individual and the family, it has important financial implications for the better. Let me say a word about interventions. As people know, the earliest interventions were psychodynamic. This is where the whole business of blaming the parents, usually the mother, came from. In this country, most children with autism were not treated in public schools. They were written off. They ended up in residential programs of various kinds where they stayed. I mean, the problem with living in an institution is you just learn to live in an institution. In 1975, there was a great sea change in the United States. It's the passage of a federal law, Public Law 94-142, which mandated for the first time school was a right for every single child if the school district took 1 penny of federal money. Of course, they all take a penny of federal money. So all of a sudden, schools had to program. They had to think about children with autism and how to teach them. This marked the beginning of a shift in treatment. It also happened around the same time that the first of the behavioral studies were coming out that were showing changes in behavior and developmental gains as a result of structured teaching. There was a nice study by Bartak and Rudder showing that structured teaching was more beneficial to the child than unstructured psychotherapy. Now, this is a slide, I purposely have muted the faces somewhat. This is a group of adolescents and young adults with autism in the pool. There's only one person in the photograph that does not have autism. And these are the kinds of children that would have been originally not very well programmed for and planned for. So this is kind of the earliest cohort of kids coming through. But what I want you to notice is every single person, except for the one girl with the ball who's interacting with the one staff member, every single person is in their own world. It's really a tribute to Lee O'Connor that he saw this. And of course, this is what we're up against. We have to get into the world of the person to make us more relevant. We know that lacking the social frame, there are major obstacles for learning and learning to learn skills. We still, are trying to understand more about the social difficulties. I'm going to say just a word about research, but I think as we're starting to move to really, as much as we can, address the social problem solving problems, we are starting to see some changes in outcome for the better. This is a study done some years ago. It's happily been replicated now many times. It was one of the first studies to show differences in face processing in the brain. The individuals with autism and Asperger's, high-functioning people, did not process faces in the same way that the typical folks did. In fact, if you look at the typical people, there's a part of the brain called the fusiform gyrus, which is right about under here, which for most of us is very active in looking at faces. It's very active for special things. If you're a bird watcher, it also lights up for that. If you're a car dealer, it will light up for looking at cars. If you're a watch repairman, it will light up for looking at clocks. So it's an expertise area. That's a big debate in the face literature. But look at the people with autism and Asperger's, no activity. Activity a little bit forward, the object areas. And again, this concretizes very nicely for teachers. Look, people are not seeing faces in the same way. It's not that they don't see faces. The faces aren't special. We've also had, and this is my colleague Ami Klin some years ago, started off a whole body of work which has its own, it's grown in multiple ways in multiple directions. But eye tracking, looking at how people with autism view social scenes. And again, one of the things we discovered, this was with a very high functioning man that I'm still very much involved with. This is about 5 seconds of the movie collapsed onto a single frame. The typical person goes back and forth between the eyes. The person with autism goes at the mouth. The problem with doing that as a strategy is if you focus on the mouth, you miss about 90% of the socially relevant affective information. This, again, for me, teaching teachers about kids with autism is very relevant because I can say, look at what the child is up against. He's getting 10% of your message. Treatment. In this country back in, I think it was probably 2001, something like that, there was a very influential report that came out from the National Research Council. The National Research Council is part of the National Academy of Science. It's tasked with answering some questions. In this case, the question was from the United States Department of Education. Does teaching young children with autism make a difference? They put together a committee. Kathy Lord was the chair. I was on the committee along with about 10 other people. We had hearings and meetings. We came up with this report which said, look, we've looked across the country. We found 10 programs that have empirical data, at least one published study, that show that their program is a benefit to the child with autism. Then we looked at these programs. They had many commonalities and some differences. One of the things we had to say is, sadly, not every child gets better, and we can't predict who does and doesn't get better. As a group, we can, but for the individual child, it's really hard. And we did say that early intervention was really important and that we recommended 25 hours a week as the minimum early intervention. It was also around this time, and you'll hear about this from Chris McDougall, that the first pharmacological studies were being done, sometimes with adults. To sum up that report very quickly, the report says, look, autism is a disorder that impacts development. At the same time, development happens. What we want to do from the point of treatment is this. We want to minimize as much as we can any obstacles autism presents for learning and maximize as much as we can more normative developmental processes. This leads us into outcome. This is a very interesting topic. Pat Helland's probably the world expert on this. I'm taking data from her 2005 summary. I'm about to tell you that I am cherry picking the data. You should always be concerned when somebody says they're cherry picking. I'll tell you why in a second. She's just redone her paper in the most recent edition of the Autism Handbook. She's updated it. It's a very interesting, very complicated area, and she, God love her, has tried to make as much sense out of it as she can. She talks about 3 kinds of adult outcome. Good means you're independent, you've got some job, you have some friends and acquaintances, you're kind of making it at some level. Fair, you're out there, but you need some support. And poor, you're basically in some kind of residential care program. You're not out on your own. We'll talk about the optimal outcome in just a second. Now, again, I'm cherry picking these data. I'll tell you why in a second. I start with literally the first study that was done, which was Leo Kanner and my old friend Leon Eisenberg. And then I stop in 1974 because in 1976, as I mentioned, in this country, all of a sudden there's a mandate for treatment. So, but look at the numbers. If you look at good outcome, we're averaging 5%. And again, keep that in mind because this is the days when we didn't have much in the way of treatment. So even at that point, some people were doing okay. Maybe 15% were having some degree of semi-independence. To put those two together, it's about 20% of people. But you also see that there's a large number of people going into residential care. Now we're moving to a different set of numbers. I've waited 15 years after Public Law 94-142, and I stopped right before DSM-4 kicks in because we include Asperger's, which might possibly skew the results a bit. And again, look at the numbers. Good and fair, we're up to, between the average and close to 40%. There's good reason to think these numbers are continuing to increase as we do earlier diagnosis and intervention. This is a very important topic. It's also extremely thorny and complicated, but we know as a practical matter, we're having more and more kids go to college. I'm going to say a little bit about that in a second. So why do changes in outcome happen? Well, we think probably the earlier diagnosis and intervention overall, and you can look at various metrics of this. You can look at adaptive skills, you can look at independence, there's a lot of things. There may be some aspect of changes in sort of broader diagnostic views, but that wouldn't have impacted those data I just showed you so much because we stopped for DSM-4. We do know that there are more and better supports, and the nice thing is they're now kind of meta books. There's a book, 400 Apps for Autism. There's a book, Technology Tools for Autism. Sort of surveys all the literature that's out there that you can pull on that to bring it into play. At the same time, we know there are issues. Not every child gets better for reasons we don't always understand. I'll see kids who I think I'm optimistic about, and for whatever reason doesn't happen. Or sometimes they get better, and then in adolescence, as Leo Connor pointed out, they tank. We have issues in matching children to treatments. In this country, a school will have a TEACH program. They'll have a TEACH classroom. Well, you might have a child that really needs a pretty strong ABA classroom. Or you've got a very young child with ABA, a young child, it doesn't always look so good. Pivotal response therapy or Sally Rogers' early start to Denver model might be a better choice. That's a kind of complicated package. And as you know, there are very few studies on older individuals, almost nothing on aging. Let me ask a question, and we'll see if anybody in the audience gets it. I guess I'll have to ask somebody to shout out the answers to me. Where is the best place to live if you believe the published data? Where's the best place in the world to live if you've got autism? I'll give you a hint. It's either a state or a province. It's a big hint. Okay, I heard Alberta. So I gotta say, you're in a cavern, so I'm hearing lots of things. I'll take you to your misery. Utah. No, Utah. If you believe the study, this is Farley et al. In 2009. They looked at individuals who actually were somewhat older, but you can see their outcome data. What's unusual about Utah? Other than it's a desert. Mormons. The church and the very supportive state. And, to echo one of our presidential candidates, not that I'm telling you who I'm favoring, it takes a village. It takes people who care about folks with disabilities. You can pick up the phone and say, my child is really giving me trouble. Can somebody come over and help out? People support the child, the community, and the family. But again, if you believe the published papers, this is the one that actually has the best outcome. And I don't want to make too much of it, but I do suspect there's something about the whole package of the community and supports that is really critical. Let me say a little bit about optimal outcome. This is my colleague Debbie Fine at the University of Connecticut's work. She reported 34 people who lost the symptoms of autism strictly defined, so they lost their diagnosis according to her. They had milder social symptoms as adults. They didn't seem to differ in terms of communication and behavior problems, repetitive behavior. But as time went on, they did better and better. Again, less social impairment. That being said, they had persistent social symptoms. So when she talks about optimal outcome, other people translate this into quote unquote normal. I would say that's actually not quite the way to put it. Optimal outcome is the way to put it. And these are people who often have some residual difficulties. I'm going to show you some samples in a few minutes of people who continue to have trouble, but who in some ways have done very well. So it's a slightly tricky problem. And she and her colleagues are now doing a whole series of papers sort of talking about the subtle deficits of these optimal outcome people. Let me say a little bit about adolescents and adults before we talk move about some of the interventions in college. So adolescents, of course, for everybody's a challenge. There are medical care issues. Adolescents cause all kinds of body changes. We know that we have some reasonably good behavioral and psychiatric interventions for adolescents. We know that often in schools, there's more needs for focus on adaptive skills, social skills supports, and communication. A lot of issues around transition issues, transition planning, a lot of issues, especially in the States, about insurance. This hopefully doesn't happen as much for you. With Obamacare, there's been some improvement, and the children can stay on as adults until they're 26 on their parents' programs. There are now mandates for coverage, which are in many ways great, except you're kind of at the pool of the lowest level of coverage, which everybody has to basically take because they can't get private insurance as a general rule. And there aren't so much in terms of social and vocational supports. There's more and more attention being focused on this. I'm sorry not to hear some of the workshops today, thinking about issues like medical home for adolescents and adults with autism. We've done a lot of work on medical home for children with autism, and it's a fantastic concept. And the question is whether we can extend that model and to work with adults, especially our colleagues in internal medicine, who often have very little knowledge, and my colleagues in adult psychiatry, who often have very little knowledge. So it's an interesting kind of time to be involved in this. Medical issues, we know higher rates of seizure disorder. We don't know about persistence into adulthood. I have a 60-year-old lady I've taken care of for years who at 58 had her first seizure. These remain a common source of difficulty. We also know that safety issues, accidents, and injuries. I say to pediatricians, there's a very high rate of accidental injury and death in autism. And they say, well, that's the highest rate in pediatrics in general. I say, yes, but it's twice the level in autism. Children who rolled and run away, who are found in the river. The symptoms of autism themselves present many challenges for healthcare. The limited activity and the social isolation can lead to obesity and associated problems like type 2 diabetes, hypertension. The medicines we sometimes use for behavioral difficulties can themselves contribute to other problems, including, for example, the atypical neuroleptics and obesity. Often we see an upsurge of behavioral difficulties in the child, I would say some months before adolescence has its sort of visible onset. And presumably that's happening as the hormones are starting to kick in. We have to, again, think about this whole set of issues as we move into adolescents and adults with autism and behavioral and psychiatric issues of how much of it's autism and how much of it's additional problems, how much it's comorbidity. This can be a real challenge in the patients with very limited language skills. And unfortunately, one of the other problems is often people are not talking to each other. The schools are somewhat apart from the medicines, and the medical part is apart from the mental health, and none of those folks are really interconnecting, which is a shame, and that's one of the things that the medical home could help with. We know that for adults, real life skills are critical. These are essential for adult independence and self-sufficiency. The Gestalt learning style that is so typical of children with autism, of learning things in chunks, which I think comes from lacking that social frame. People don't learn to multitask if they're not very social people. So they learn things in chunks, they don't generalize, they can't apply. I'm going to give you an example in a little bit of a man who is a math genius. He cannot walk in, he's got an IQ of 140, he cannot walk into McDonald's and get a cheeseburger and change. And it's not the math that's holding him back, it's the social demands. And I can tell you, McDonald's, if anything, is one of the most single consistent places to go, except, of course, there's a young lady behind the counter. And she's got her perky McDonald uniform on, and he walks in, he wants to order a cheeseburger. And she looks at him and smiles, as she's been told to. She says, hello, would you like to try our chicken fajita? He had not come in for a chicken fajita, right? He'd like to have a girlfriend. Maybe if he buys the chicken fajita, she'll be his girlfriend, but he didn't want the chicken fajita, so he flees. But again, it's that kind of problem, and it can be a real life-limiting step for the more able. Other issues, driving is a very complicated task. It's got a lot of executive function aspects, and it's very social. You got to keep in mind that even other people, they may not follow the rules, even if you're good at following the rules, and you have to take that into account. So again, it's a very interesting, and again, there are resources. There are now some virtual reality programs for teaching driving skills. There are a handful in the United States of special needs driving instructors for kids on the autism spectrum. Communication skills, we want to help even nonverbal adults be more communicative. And again, we have a whole world of literature on augmentative and alternative communication. This stuff can be high tech, it can be low tech. It can be computers, assistive devices, iPhones, things like iPrompts, some of those 400 apps for autism. It can be low tech schedules. The group home that I consult to every week, everybody's got an enormous bulletin board that shows their week in pictures. They go down the day, as they finish activities, they turn them over, and then they can see what's coming next. They can see what's later in the week. If they want to, they can review what's happened in the week. It's very helpful. Only 2 of the 6 people are really verbal in that group home. But again, it helps them get through their day and their week. Legal issues. This is a problem. For the people with Asperger's, there's some literature, which is mostly British actually, talking about problems of violence. I certainly have seen some children with Asperger's who committed acts of violence. In general, however, my experience is these are people who are kind of overly moralistic, and they focus too much on the rules, and this gets them into trouble. For example, one young man I worked with for a couple of years who was in high school, did pretty well academically, but very socially awkward. He would love to have a girlfriend, and we had practiced at some length ways to make conversation with girls. How could you ask a girl out on a date? We've been working on this. He sees a girl in the grocery store that he knows from his Spanish class or whatever it was, and she's shopping. And so he is trying to come up and talk to her. And under his breath, he is practicing what he's going to say. And we practice other kinds of things for school. We've never practiced what he's going to say in a grocery store. And so he's practicing, he's trying to modify, which is great, but he's talking to himself. So the girl sees this guy, and he's kind of mumbling, and he's following her. And she starts to get nervous, and so she kind of moves. He moves in parallel. So she's getting really nervous. And she rushes to the checkout line, as she should. There's an adult there, as a parent of 2 daughters. I say, that's great, do that. But she gets there, and she's in the line that has the sign that says 10 items or less, and guess what? She's got more than 10 items in her cart. He starts pulling them out so she won't get into trouble, of course, without explaining. And the police get involved, and it's a whole to-do. But that's the kind of thing. I know of a girl who was a girl, it's amazingly enough the case that I now sometimes talk to judges who know about these kids. And I was in Brazil, and one of the justices of one of the high-level courts in Brazil, who herself is a parent of a young man with Asperger's, told me about a girl from Sweden who'd been on vacation in Brazil. And on the way back at the airport, somebody came up and approached her and said, oh, I've got a package for my mommy, my grandma, who's working in, Uppsala or whatever, and she's going to come to the airport to get it. Would you mind carrying it for me? And so you can imagine what's in this package, right? The lady's in jail for carrying pounds of heroin. And fortunately, this judge, realizing that this girl had Asperger's, was going to be in jail for the rest of her life in Brazil, got her basically exported. It's that kind of thing that often causes people to have trouble. For the less able students, meltdowns and aggressions and communication problems, also their difficulties with fast information processing can lead to problems, especially in public settings. We have police being called. The police and other first responders have variable degrees of training in this. And again, there are principles that we could convey: slow things down, help the person be calm, try to find out, don't have a big blow up, don't tase them, right? It's hard because a lot of our first responders have not had so much training. There's more and more of an emphasis on that, certainly in the States. There are lots of issues as well legally in terms of parents thinking about planning, future planning, estate planning issues. We had a famous playwright in the state named Arthur Miller. He was the parent of a child with Down syndrome. And that child was trisomy 21 for many years, has resided in the state group home. Obviously, if I'm talking about a case, it's public knowledge, that one of the state residential facilities for adults with mental retardation. And in his will, Arthur Miller left him flat out exiting $1 million. Well, the state comes in, swoops in, takes all that money back because they were paying themselves for all the care they've given over the years. Had he put that money into a trust for the benefit of the young man could have enjoyed the benefits of it. So it's that kind of thing. And again, there'll be different issues depending on what jurisdictions, but to some extent, this cuts across all kinds of problems. Or parents of high-functioning people who just assume that they're going to be legal guardians. And in point of fact, under the law, the presumption is, no, you're not at all. Similarly, parents who just assume the sibling will take over the care of an adult. And in point of fact, they've never discussed it. The sibling wants to be 1,000 miles away from it if he possibly can. So it's that kind of thing as well. Again, we need better models for police and emergency training. basic information on what is autism, how do you recognize autism if you see it in the street, how do you approach, what do you do and not do. This, of course, is not just autism, it's mental health problems in general. We also know that for our population, I'm not going to spend a lot of time talking about this, but if you're interested, I can tell you a lot more about it. There's a great resource. Bullying can be a very major problem. And again, most of the bullying data is based on surveys, it's self-report, but it's not necessarily, it's complicated knowing who's really responding. That said, the short version is probably about 40% of adolescents and young adults with ASD will experience bullying at some point in their life. If they have autism, ASD, and something else, they're anxious or depressed, or they got ADD, that number probably goes up to something like 75%. So let me just give you a quick example. And again, this is obviously a person who's not a patient, but it's public information. Anybody know this man's special interest? He's famous in New York City. This is a man named Darius McCollum. And Darius McCollum has a special interest. He likes subways. He likes subways so much, he hops in them and drives off with them. This does not endear him to the police, nor to the transit authorities. The first 2 times, I think, the judge kind of let him off, and the third time the judge said, prison. But that's the kind of thing also you'll sometimes see special interests. I just got a call about a case, I won't give you all the details, a federal judge who picked up on the fact that the person had what he thought was probably Asperger's. And in fact, we have a whole discussion. The person was an immigrant from the Caribbean, probably in point of fact does have Asperger's, and got into trouble by visiting federal facilities, wanting to see things, and mixed it up with a federal guard, who told him he couldn't be there after hours. And again, the judge is trying to be helpful. God love them, as indeed many lawyers discover that often what they're doing is social work. Living arrangements, we know that there's a range of things from group home to supported independent living. I also know that more individuals with autism are marrying and having families. I have a number of folks now I know who are having kids. There's no research I'm aware of on this. There are books. There are books, especially from Jessica Kingsley, on how to have a relationship with the person with Asperger's, etc. But we obviously need to look at the offspring. That would be a fascinating topic. I'm not aware of any research on this. There are pros and cons of residential programs. There are more and more transitional programs. I'm going to say more about that in just a second. We have, again, a range of options in terms of adult work. Early on, way back in the 80s, sheltered employment was what people talked about. Now it's more supported employment and even independence. We're also seeing with more education and more adult learning, people continue to make gains, although autism can present continued challenges in the workplace. At the same time, people on the autism spectrum have many advantages. They're very loyal employees. I have somebody who works for me who does copying. It doesn't matter if it's a foot of snow, 3 feet of snow, he'll be here. I have, fellows who a flake of snow falls, oh, I can't come in, it's too snowy. This guy walks a mile to get here every day, and he's very reliable. He's very trustworthy. He's very dependable. He's very efficient. But again, those kinds of things, if you can educate employers about strengths and find a good match for the person and the job, you're in great shape. The strengths and weaknesses, again, important to think about. Computer-related things, things where you can kind of go boom, 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 where it's more straightforward and linear, as opposed to a little complicated multitasking. There's a small body of work, as I mentioned, available on this. There are more and more things in terms of chapters and other kinds of resources. The empirical work is probably about 20 papers. Colleges. I think we're doing okay for time, and I'm sure somebody will tell me if we need to pull the plug. College is not a right in the United States. I don't know about Canada. In college, the law changes. Up to the point when high school, where you get a high school diploma, you're covered under what was Public Law 94-142, and now is IDEA with its amendments. At high school graduation, that law stops. You're out. You're into a new law, the Americans with Disabilities Act, which provides for reasonable accommodations for folks with disabilities and prohibits discrimination against people with disabilities. This is a whole set of issues. It comes up really in colleges, and sometimes we'll talk about transitional programs. They can be helpful for students who are on the cusp of being able to make that big leap to college. We also know, interestingly enough, and this is a study I highly recommend by Susan White, Tom Allendek, and a couple of other people, I believe. It was published in 2001. She looked at a large sample of students just selected from her university, not kids on the autism, not kids known to have autism. So a big group of kids. She did both a categorical and a dimensional system of diagnosis the SRS, and I forget what the categorical one was, depending on the method, between 1% and 2% of the students met criteria for ASD. Of the 5 students who had met the stricter diagnostic criteria, none had been diagnosed. And again, this is a whole interesting problem because we are seeing kids who make it far along who never had a diagnosis, who are always known to be somewhat odd, but who have managed to kind of make it. And here they are in college, and suddenly we're confronted with people who, for the first time, need to have a diagnosis. Now, the good news about colleges came out of monasteries. Monasteries are ordered, they're structured, they have routines, they have schedules. Colleges have things, you can show up and get food, you can show up and get books, there's entertainment. Depending on the school, you can minimize social interaction. You can be a little book, hermit, you can be kind of holed up in your cubby and do your own thing. At many schools, some schools like Yale, it's much more social. But again, at many schools, you can really kind of do your own thing. So the challenges, high school and colleges are fundamentally very, very different. High school, you had a lot of tests to help you keep up with homework. College, you might have a midterm and a final. You might have gone from a class of 20 people to a class of 500 people. They had one building in high school usually. In college, you have many people. You got to get around. All these things present challenges. And we know that we can make accommodations, doing things around giving extra test time, giving extra time for tests. We know the areas that they're going to need the most help: English classes, group work in labs, essay questions, classroom behavior is a big area. You can't have your hand up all the time. You have to think about when you're going to talk and be very careful about it. Also, especially around sexual issues on campus, there's often very limited tolerance for unusual behaviors. And that causes a lot of trouble for many of our students. The college student has to be self-advocating, motivated. They have to have good study habits, etiquette. They have to plan their own time. They have to learn to rely on some of these technology tools to help them not to get stuck. They have to be flexible. They need a lot of support. They need both social and interpersonal support. Things like how do you date, learning to tell jokes, learning to understand jokes, being more independent, things like even laundry. I have one student I worked with for a while who every other week for the first year of his life here at Yale was boxing his clothes, his dirty clothes in a big box, and sending them to his mom in Virginia, who would wash them and send them back. And the reason was he could do the laundry. The problem was even at 2 a.m, there'd be kids in the laundry room. They'd be talking, they'd be picking each other up, they'd be drinking, they'd be doing stuff. He just couldn't cope with it. It's that kind of thing, of course, which is where life is lived. Cafeteria, shopping, going on your own to the doctor, managing your own medications, money. These can be big challenges. The students can be resistant to asking for help. In the US, if the student doesn't ask for help in college, they don't get help. The parents can talk up a blue streak. It doesn't do any good. The student has got to do it. And depending on the college, there are going to be various kinds of help available, which for us is a real challenge. There are 5,000 colleges in the US. They're all over the place on this. We know that assistive technologies, proofreading program, note takers, recorded textbooks, speech to text, text to speech, all this can be helpful. Having some flexibility, changing test procedures. Sometimes students in tests get very upset by noises. Let them sit in another room and take the test by themselves. Tutoring and special mentoring can be really helpful. I have a program I've done now for years where I have college students who are going out and mentoring some fairly high-functioning kids who are in a special program here in New Haven called Chapel Haven, which is transitioning those kids to college. The supports available, again, often there's extra time, there's social supports, mental health supports. This in the US varies tremendously from campus to campus. And again, student has to give permission if the parent's going to be involved in the discussion, and we need to plan in advance. I tell parents and kids as they're looking at colleges, look at the mental health supports, look at the Learning Disability Support Office, the Disability Support Officer, get to know what's going on, talk to some of the kids on campus. But again, people have to do their homework to see what's available. Some children, some young adults in college decide, well, I'll go to a commuter school. I'll live at home, that'll be simpler, and I'll take the bus or the train or maybe even drive to college. That's a choice. It has pros and cons. If you're living at a college, you have a lot of residential issues. You have friends, you have suite mates, you have laundry, personal hygiene issues. We had a program here a year ago for high school students interested with autism spectrum, interested in going to college. And my friend Jane Brown, one of the early things she said in the group, which was kids and parents and teachers, was that if the mothers were still involved in their boys showering, they needed to cut it out. And there were gasps in the room as mothers realized they were still involved in helping their teenage son shower. Sleep patterns, we have kids, sleep problems are very common. They're up in the middle of the night. That's not totally out of the question of college, but it can cause issues. The sexuality issues are very common. Social skills teaching, again, you can do a lot of life coaching around this, and it can be very helpful, and people appreciate it. What you can talk to who about what? What do you say? How do you have a conversation? How do you self-correct? Am I telling you too much about this? Would you like a turn now? Teaching explicit meaning of gestures. Idioms, sarcasm. Again, explicit teaching, there are some resources now about this. If anybody asks, I'll tell you there's some good video resources by Dan Coulter. There's a great set of videos for high-functioning kids on learning about puberty. There's one for boys and one for girls. You have to assume nothing and teach everything, especially boundaries. Pros and cons of 2- and 4-year colleges. 2-year colleges are great. You can open enrollment, you can take a small number of classes, you can sort of get a track record, then you can move on. The cons. Academically, these can be much less challenging. The kid will feel badly because he's much smarter than his classmates. At the same time, he's much less socially competent than his classmates or hers. This can contribute to depression. Mental health services, you need to think very broadly about this. Traditional mental health supports, but also the academic supporters involved, and even if necessary, speech pathologists to help around social pragmatic issues. There's one survey looking at the most frequent problems overall for all kids in college, for everybody in college, everybody, not just kids on the spectrum. Anxiety, very common. Depression, very common. 10% of students had thought about it. 11% said they had a learning problem. 30% overused alcohol, they said, and 4 to 5% had an eating disorder. We know that in kids with autism spectrum disorder and Asperger's, depression is very common. There may be some genetic vulnerability. We have agents that can help, such as SRIs and even the older tricyclics. The psychotherapy, especially with CBT, which has been modified for kids on the spectrum, can be very helpful. We know that with greater self-awareness, the good news is the child and adult is spurred to do more. At the same time, that greater self-awareness may contribute to the depression. And there probably is an increased suicide risk. There's one study from Canada on suicide rates in autism reporting an elevated risk. Anxiety, again, it's complicated because it comes from probably different sources. There's frequent victimization. People are worried all the time. They have difficulties with transitions. Everything is always new to them. They have trouble generalizing from one setting to another. We have a number of agents that can be helpful. And as always, we have to balance risk and benefits. There's sometimes this trouble with disinhibition, with over-sedation. Learning issues, again, we can support learning problems when you can demonstrate needs for executive function, IQ testing. We can have things like extra time for tests. We can have accommodations that are reasonable. At least in the US, it doesn't have to be the best. It has to be reasonable. Substance abuse. This is an interesting thing I've gotten more and more aware of in the last couple of years. As kids are going to college and doing better, like all kids in college, they are at risk for having problems with self-medication, especially with alcohol, but I've now had a couple of kids who had heroin problems, and they were kids on the autism spectrum. And clinicians probably should be alert to this. There's a small literature on this, but it's growing. There's a review a couple of years ago now in JAD, which looked at college students with ASD, all the studies. So it's a meta-analysis. Only 2 of the studies were experimental. The problems, anxiety and housing, were the most common things. Many of the students had peer mentors. Many of them had counselors. Their parents were involved a third of the time. And there was single case report about some interventions. So you can see this is kind of the state of the knowledge of the college literature as it stood in 2014. Social supports, again, continuous social teaching, that whole package of stuff. The presentation of mental health problems is very varied. You can have depression and anxiety. You can have a behavioral outburst, but in point of fact, the person is anxious and depressed. Any change in behavior can signal a problem. What's the secret to intervention in this population? You have to be explicit. By explicit, I mean really explicit. No, it is not okay to talk to the lady about her breasts. Yes, they are big breasts. It's true, but we don't do that. In polite conversation, we do not do that. Write that down. Rule 153, no breast talk. It's that kind of being very explicit that's helpful to the student who wants to learn. Mental health services, again, parents sometimes come into this with, some anxiety about mental health, folks given that very old history, and thinking traditional psychotherapy is not going to help, which is probably true. Sitting around for a year waiting for the person to talk about their mom, and I ain't going to do it. On the other hand, if you take a life coaching model, you're very proactive, you give advice, you help kids solve problems, and you assume nothing, this can be extremely helpful in my experience. You have to be flexible. You have to have more of a teaching model. Social skills groups can do this to some extent, but even in psychotherapy, or for that matter in social skills group, you can do homework, you can do role play, you can do videos, diaries, etc. You can encourage homework. I want you to go to McDonald's and order this. Doesn't matter what she says. Let's practice. What do you do if she says, have a chicken fajita? I say, I really want the cheeseburger. Thank you very much. But again, having this and really helping the kids can be very motivated. The trouble is, this is very time consuming. And again, I think it's very helpful, but it's really very labor intensive. We can teach problems like, how do you deal with novelty? How do you know that you're anxious? Oh, I feel my palms sweating. Oh, I feel myself sweating. Oh, I feel my heart pounding in my chest. Oh, that's what Dr. Volkmar told me. That's when I know I'm anxious. But again, things like that, teaching lists, scripts, rules, again, a whole package of intervention approaches that we can really take, I think, quite fruitfully into the discussion in this population. Psychotherapy, broadly defined, can be used with medication. Again, coordination is important in terms of having everybody talking at the same level, at the same page, and having a network of supporters. The nice thing, I think, about getting, especially in these days, younger people as a group are more inclined to support people with disabilities. They really don't write them off. They really are encouraging them. They want to include them if they possibly can, but sometimes they really need to be helped in terms of having strategies. Again, CBT, we have a whole set of CBT studies now in autism with modifications. There's a whole package of things we can do based on CBT that can be very helpful to the person with ASD. Let me give you a quick example. You remember my man with, who couldn't walk into McDonald's and get a cheeseburger and change? Take a guess as to what this next page of equations is about. He's a guy who lives in a math world. He solves equations in his head all the time. He has a favorite mathematician, Dauphinus. He does Dauphine equations. I didn't even know there was such a thing. A real math genius. He knows a lot about clocks and watches. He's kind of a classic kid with Asperger's. IQ 140. And interestingly, his verbal IQ has always been very high. The first time we saw him, when he was about 9, his nonverbal IQ wasn't so good by a long stretch. It came up dramatically when we saw him again at 11. And what he had learned to do on his own was to use verbal strategies to solve nonverbal problems. So for example, on the block design part of the Wechsler, psychologist is showing him a red triangle in the field, giving him some blocks with red, white, and red and white on a diagonal inside, and he's supposed to make this triangle. He gets a perfect score. And the psychologist got to love him and said, how'd you do this? Because you didn't do so well last time. And he said, how do you do it? I have to imitate him. Well, don't you see? This is a math problem. I have to make it a math problem so I can solve it. So the red blocks, those are 1s, the white blocks are 0s, and a half are 0.5s, so it's just matrix algebra. So he's developed a verbal workaround for this quintessential nonverbal problem on the Wechsler. And he gets a perfect score. Because he's not seeing some dorky shape. He's seeing strings of numbers. If he sees it as a matrix, he can do it. But again, this is the kid, and he's working on this problem. Here's the rest of his equations. This is all about, he's modeling for himself mathematically. Will I ever get a girlfriend? Now again, the fact that he's approaching the problem this way tells you pretty much that the answer is no. Sadly, and you can see his final solution at the bottom, which is 0 equals 0. This is also a person who's attempted suicide multiple times and who would love to have a girlfriend, hasn't the faintest clue about doing it. So needs in terms of research and service, we need more evidence-based treatments. There's a big emphasis these days in this, practice guidelines. There are practice guidelines from the American Child Psychiatry Group that have been recently revised. There's the NICE guidelines, the SIGN group in the UK and Europe. So there have been attempts to translate research into recommendations. This is great. We need more and more evidence-based treatment. We need more looking at models of care, and we need to get more information out to people, including policymakers. One of the funny things in the United States is we have 50 states with 50 experiments, essentially, in terms of education for kids on the autism spectrum. Nobody's looking at that. Nobody can look at it. Nobody's got the data. But again, that's the kind of thing that makes much more sense. In summary, there's been many advances. It's a very exciting time to be involved and work with adolescents and adults. We clearly need a lot more information basically in all areas, especially on aging, health and mental health, quality of life. This is a real area of difficulty for many people who are even the highest functioning. I have people who are living here in New Haven, who have jobs, who are very isolated and lonely, and they don't have a great quality of life. And looking at supports and what we can do in terms of helping people get more from the community. So let me thank you at that point. And since I'm from Yale, I've got to end with a bulldog. So I hope I didn't put you to sleep. And there's some references that you will have. And again, I think you probably have these already on your PDF. And here's a few more. And again, I recommend that Gelbar look, but there's some very good resources out there. And this shows you just some of them that may be helpful. And finally, my apologies for the weather. I really, truly wish I were with you as opposed to sitting in New Haven, where it's going to be 40 degrees today. Go figure, it was 50 yesterday. So let me stop there and see if we can figure out a way to answer questions. Okay, thank you very much.
Very much, Dr. Volkmar. Can you hear me?
Great.
Can you hear me?
Yes, we're going.
All right. So we've got a very complicated card system here, and we're asking that you write your questions on the cards, and then I will communicate those questions via microphone to Dr. Volkmar.
Listen, I think that's a great system. I once was giving a talk in Albany, New York on Asperger's. I'm giving people time to write their questions. And I'm in the middle of this building, which is called the Egg. And the reason it's called the Egg is it's because this big egg in the middle of the Empire State Plaza, there's this enormous egg. You feel like you're walking into a spaceship. And so I'm giving this talk to 150 people or so on Asperger's. And this is where I learned about writing questions down. And I'm halfway through the talk in the morning. Somebody stands up in the middle of the room and shouts out a question. And of course, the fact is the person shouting in a monotonic voice, I have some sense it's a person on the spectrum. And he looks at me and says, Dr. Volkmar, I've got a question. So I, fool that I am, say, what's your question? And he looks at me and says, I want to know if it's normal for a man my age to have a continuing relationship with a plastic blow-up woman. As I told my wife later, it was like Moses parting the Red Sea. People are moving away from the God. And I learned it's better to have some questions on cards, because you can say, the person who asked about the plastic lady can come up and talk to me afterwards. But I know that's not Canadian, so.
Okay, Fred, we have your first question.
Good.
What's the point of diagnosing ASD in an adult who's not been previously diagnosed? Why bother with a diagnosis?
Well, that's a very interesting question. There's kind of a practical answer and there's a deeper answer. The practical answer is, does it help guide treatment? Yeah, you can give the person anxiety and depression and blah, 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 and some social skills training, and it's true, but you've kind of missed the big picture, which this is a person who has a fundamental social disability. I've taken to talking about autism as a social learning problem, because I think I was giving a talk to some Boy Scouts in Wallingford who had a person join the troop with Asperger's and who left because they couldn't figure out how to talk to him. He only wanted to talk about his toaster collection. And I realized in talking to these Boy Scouts, the autism Asperger's labels, it got them kind of nervous. So we talked about disabilities, visible disabilities, learning disabilities, hidden disabilities. And I talked about social learning disabilities, and that led us into talk about strategies for helping, which is the kid talked about his toaster collection. You say, no, I'd like to tell you about what I'm interested in, or I'd like to hear about you other than your toaster collection. But again, stuff that falls out from having a helpful, that's kind of, in some fundamental basic way, that's the point of the label. In this country, in the US, it would get you some rights as a disabled person. Now again, there's a whole discussion about is it a disability, isn't it a disability? And again, that I don't care so much about, except if people are in need, it's nice to be able to offer them some protection and services, and it would give you some protection. And again, the examples of the people running into trouble with the law, who sometimes are undiagnosed, that can be very helpful sometimes to give input to the legal system. And of course, at a deeper level, it's a question of what do we use diagnostic labels for? Way back when they were used for purposes of public health planning, they were looking at causes of death. They were kind of using them to sort of plan around in society and trying to understand, well, why is this why does this town have more of X syndrome than the other? So that was kind of the basic reason. But it was a reason kind of thinking about public planning. I think also it speaks to the issue, especially these days, of these missed cases. Well, that's part of the reason we've seen this quote unquote explosion of diagnostic labeling, is we're picking up cases that in the past would have been missed because they're kind of at the edge of the spectrum. And again, I thought that study of Susan White's was very good at talking about this because she's looking at a large sample of kids, between 1% and 2% would qualify on either the SRS or the ASQ, whatever it was. So I think the question is, does it translate into something to help the person? Will it help the person understand more about themselves, that they have a social learning problem? Again, that's the whole package. If it doesn't make a difference for the person, who cares?
Thank you. The next question is, does applied behavior analysis therapy help with older kids and adults with ASD, or do you think that there are other strategies or interventions that are?
You know, there are many good programs. If you look at programs, I'm talking about programs and not techniques, okay? If you're talking about programs, there are some very good programs. They kind of fall into 4 categories. This is, again, sort of school-age, high school type programs, but it's kind of the overarching programs. We've got ABA, which is a long and distinguished literature and history, thousands of cases. People with ABA background will say, oh, there's thousands of papers. Yes, it's a lot of cases. It's mostly case reports. I'm not knocking that. Then we have some more developmentally oriented programs. Sally Rogers is probably the best one of those, the Denver Early Start model. We have some programs like Teach that are very kind of eclectic, that pull from a lot of different traditions, and they have their own kind of background in philosophy, and that's partially evidence-based and supported. And then we have some programs, for example, pivotal response therapy, that draw on both behavioral and developmental principles in coming up with strategies. And now with younger children, we are starting multiple ones of us around the country. We've done some work here at Yale, Sally at California, looking at brain changes in response to treatment in younger kids. There's no question that all the strategies can be used. ABA is very applicable to adults, and is to all of us. Applied behavior analysis, again, especially for the lower functioning, is one of the more effective treatment modalities, combined, of course, with other kinds of evidence-based treatments that can support communication as much as possible. So you can think about behavior, but not outside the context of the individual and what their broader package of needs are.
Thank you. We have a question here about the requirement to have an IQ of less than 70 in Ontario, and I imagine in parts of the States as well, in order to access funded developmental services. What do you think about that problem, you know, the whole IQ issue in terms of access to developmental services? Obviously, we're seeing fewer and fewer folks on the spectrum with an IQ under 70 now. So that certainly presents some problems for our community.
That's a real problem. And it's a problem here in the States as it is in Canada. And, you know, it may have made sense way back when, but it no longer does so, because these are people who, with a little help, might be helped to be quite functional. And again, that's the kind of paradox of this. And it's very sad because we get people, and again, we have a few programs in the US. New Haven, it turns out to have a quote unquote waiver that we can provide some support for people who would technically not qualify because of the IQ business. As a psychologist in the room, you know that often when you're dealing, especially with this population, the kid can be the young adult can be all over the place in terms of their cognitive testing. I mean, I've had kids with a 70 and a 140, it's the same kid. You know, you come up with an overall IQ, it's very misleading. And most psychologists in all good faith would never report an overall IQ. So that's, you know, the whole package is somewhat set up against the sad fact that our kids with intervention are doing better. I think the other problem is there's such a dearth of studies. And again, I'm not advocating one candidate over the other. Hillary Clinton came out with a statement on autism and saying that it's one of the disorders she wants to target. And one of the things she talked about is a study of adult needs assessment, which I think is great, because if we could look at if we could demonstrate in a good way what the needs are, then we could think about planning for supports. One of the problems is, given how small the literature is, it's hard to make the case. I mean, we probably at this point, in terms of social policy, do a better job of saying the economics and saying, look, we can move the kid from being totally dependent to being independent, we're not talking about quality of life. And again, there's a very nice review of quality of life issues in adults with autism. Pat Hallen talks some about it. There's a nice review by, I think it's Mia Chiang, Chiang, on quality of life in autism. And again, there are many, many issues for our adults, even when they're quote unquote high functioning or optimal outcome, as Debbie Fine talks about it.
Thank you. I'm wondering if you can say a few brief words about research on the cause of autism and how that relates or may relate to the dramatic increase in incidence in recent years.
Well, I think most people who are serious researchers in the field are somewhat skeptical about the dramatic increase. I was asked to comment. There was a recent federal agency that put out some new numbers that said their numbers were now approximating the CDC's estimates of autism. And you read the paper, they called around the country, they're calling a random sample, thousands of cases, and their autism question was this, to the mother, I think to the mother or the father, but probably the mother mostly, has anyone ever mentioned the possibility that your child might have had autism? Well, these days, we have radio ads all the time about autism. And so that's their criteria for getting in. And in this country, to get a label of autism gets you the most services. So there's a push to get the label to get services. And it's back to this whole business of diagnostic substitution, diagnostic overshadowing. So it's a tension around what are the real numbers. My guess is, especially if we think more broadly, as we often have, not just of classical autism, but a broader spectrum of social vulnerability, disability, then you get relatively high numbers, on the order of 1 in 100 people. But that's not very far off from way back when we were talking about PD and OS, 1 in 150 to 1 in 200. So that's kind of the tension here. And again, the question is, how much support do they need? How much help do they need? One, I think, of the big accomplishments over the last 30 decades has been opening up our view of autism from a very early, strictly defined counter cases, this broader range of social dysfunction. And again, if you get to that broader range, you're going to get bigger numbers just intrinsically.
Thank you. Are there any adults on the spectrum who cannot benefit from pharmacotherapy in addition to other therapies?
Chris would be a better person to ask about this. You have to be judicious. Pharmacotherapy is probably overused, especially in people on Medicaid. I think there's at least one published paper, and I can't remember now, but I think it was adults in North Carolina on Medicaid. And there were a fair number of people on 3 or 4 psychotropic medications, as I recall. I'm not getting the numbers right, possibly, but there's a tendency probably to over-medicate. That being said, there's no question that, as for all of us, medications sometimes be helpful. They don't substitute from a bad program. And again, I think you have to be a little careful. I had a lady call me up not too long ago and talk to me about her daughter who was pretty classically autistic and said she needed medications. And I said, oh, I'm sorry to hear that. I'm surprised because she seemed to be doing so well in school. And she says, well, on the bus. And I stop her and I say, excuse me, but only on the bus? Only on the bus. What's going on the bus? So the kid on the bus, there's another child who's on the special needs bus who's a screamer. My patient is very sensitive to sound. So rather than medication, we give her an iPhone with music to listen to. But that's the kind of thing you have to be a little careful of. I think medications have a very important role, and we have to, again, keep them in mind, but also keep in mind the potential risks and benefits, as we always do, and they're not going to substitute for a bad program.
Fred, can you talk a little bit about programs that may be implemented in the States or around the world for transitioning from high school to post-secondary education?
This is a growing number of programs. There are probably 20 to 25 programs around the country, and that number is growing. These are programs that really build themselves as transitional programs. There's 1 or 2 programs that are really totally self-contained, small private colleges where kids with autism, ADD, they can get a regular college degree, but it's extremely small, very tightly run program. It's very expensive. There are other programs. Chapel Haven would be an example of this in New Haven, where the person comes, they have a residential program, they have classes at the residence, things like how do you have a roommate, how do you have a bank account, how do you cook for yourself, how do you do the laundry, that kind of stuff. functional skills. They go to one class a week at a local state community college to learn about taking college classes. And the idea is to sort of build up expertise to have them move on. There's another one here in Connecticut called Thames Academy. It's part of Mills College. You apply to Mills College for this special program. It's a 2-year program. I think about half the students then go on to get a degree from Mills College. Lovely place out in New London, Connecticut on the ocean. And it's great. The students live in 2 dorms. It's a very well functioning, it's a very integrated program. But again, they sort of go out and explore the campus. They have some classes. There are programs like that around the country. Colleges have seen a marked increase in the number of kids going, self-identifying as having special needs. As far as I am aware of at the moment, I think there are 5 Yale students that have autism. I mean, I know a couple of them, not surprisingly. But it's interesting. I think, if I recall, University of Texas at Dallas has hundreds of kids who self-identify as having autism. I may be wrong about that. Look at the video with Jane Brown and me, which is about to be posted on YouTube, because she talks about this. But there's one school in Texas that has a large population. That's a regular school, but they have some supports. Many schools around in the country, and I know the ones in Connecticut, for example, Gateway College here in New Haven, Western Connecticut State, Sacred Heart, have small programs that will support a handful of students with autism. They're not residential typically, but they're around some of the social supports and some of the executive functioning supports, the academic supports. So those programs are increasing around the country, partly because there's a market for this, partly also because there's a growing need as kids are coming out and they're just on the cusp of being able to go to college, but not quite. And that's often the dilemma. I mean, we see kids who are academic and the parent shows us. I mean, the problem is, I'll see that like a family last week, the mother starts out saying, well, as we look at colleges and our college search, and Jane Brown corrects her and says, I'm sorry, I mean the students' college search, the students' college. Well, but that's kind of a big problem already. It's not our college search, it's the student search. And we have to make it about the student and what the student wants, not what the parents want. And the parents can be fooled sometimes by very good academic skills and dreadful real life skills. And I see to some extent the same thing in parallel. We have occasional problems now because there's an emphasis on inclusion, which is great. I'm not knocking it at all. I know one young man who was included in a high school. He's taking as a junior in high school classes on the American Civil War and the Constitution. He's totally nonverbal, very dysfunctional, not totally toilet trained, does not shower independently. That is a waste of his time. Again, it's great that he's sitting there, maybe, but somebody should be teaching him functional skills. And again, so that kind of issue. And as adolescence hits, at least in the States, there's a mandate at age 15, the student should be included if they've got an IEP. The student should be included in the individual educational plan. But the student has to be there. And that's important, and it's something that should be taken seriously by the parents and the teachers. We need to look at what the student's interests are, try to help the student gain some experience in vocational programs. But again, there's a whole number of these programs around the country, and they're more and more every year.
Thank you. The next card asks some questions about females and Asperger's. It seems that we're recognizing the diagnosis in women much more, but we're also seeing borderline personality disorder being applied to these women prior to a diagnosis of ASD. Can you comment on women and ASD?
Well, we used to say that the accepted knowledge was that among higher functioning people, meaning people with IQs in the normal range, the male-female ratio was something like 25 to 50 to 1. And there's no question it's more common. I think the problem is that in women who have social vulnerabilities, possibly because there's some kind of compensatory either mechanism or actions, often the deficits are somewhat subtler. Often they're not so sort of in your face. And again, people are paying more attention to this. I think it's an important topic. We're learning more about it. Now, at the same time, at the kind of edges of all these things, there's a lot of potential for disagreement about diagnosis. And sometimes it gets very convoluted to sort it all out, especially by the time you're disentangling years of experience from early developmental problems, who knows what kinds of therapy and life experiences. It can get very thorny. That being said, I'll give you a quick example of, I was watching one of our psychology postdocs doing an IQ test on a little girl from Texas. And the kid, she got out the Wexler and she had the triangle. The kid turns the triangle upside down and she says, it's a ventnor. And the psychologist keeps going on and, does her thing. And at the break, I said, go back and ask her what a ventnor is. And so she asked her what a ventnor. The little girl goes through her backpack and pulls out her book of cows. It turns out there's a cow that has an upside down triangle on its flank on both sides. But again, she didn't hit you over the face. She just mentioned it in passing. But that's the kind of interesting thing about the subtlety of the differences. And I think it's a topic that needs much more work. There's a fair amount coming out in terms of the non-peer-reviewed literature, less so in the peer-reviewed literature, but a little bit, and it's growing. And I think as we get more knowledge, we'll have a better sense of it. We certainly do see people, including sometimes people going to college. And I know of a number of girls who've gone to college, some quite successfully.
Can you comment on the role of natural maturing in the life course for people with ASD?
Sorry, just to be clear, the role of natural maturation?
Yes.
Okay. Also, there's no question that people get older. Often we see behavior problems that were more problematic in early childhood, middle childhood, early adolescence diminish. So there seems to be some sort of tendency, I think, in general, for I don't want to say a calming. For many people, the behavior problems become less acute. They can still persist, though. But we see some changes, I think, looking at everybody. The problem is we don't have enough of a developmental perspective. Almost all the outcome studies are in young adults. They stop. And we don't know what happens after. And again, I think if we had some perspective in terms of needs for adults, we do a much better job of saying, well, what's kind of the natural course? We do know, of course, also, that's complicated to disentangle this now because we have more and more effective interventions that are starting earlier. So we have these two things that we have changing outcomes as we're doing intervention. At the same time, development happens. And so these two things are kind of going along in parallel, but they're interacting with each other. So it makes it, I think, very difficult to sort out. But it's a very interesting and important question, I think, especially if we had people with multiple time points, so that we could really try to get more of a sense of what the trajectory is. And again, I would emphasize, underscore, boldface type. It's really hard to predict early in life. I have a young man, I've got a video I'm going to show him in my class in 2 weeks. At 2, he's circling, or 2.5, he's circling around, totally nonverbal. He's spitting, doing what his mom calls airplanes. I've got the same kid at 15 years of age doing stand-up comedy in a nightclub. And again, go figure, right? But that's the problem. You can't predict we get better predicting as kids get older, but even then it's a little complicated. So this whole business about the life course is fascinating. Really goes back to the Connor Eisenberg study I mentioned in the first outcome study, where they talked about some kids in adolescence really taking off for the better, other kids going down the tubes a bit, happily not so many. And then of course we have the other problems of psychiatric comorbidity, medical comorbidity with epilepsy. Person develops epilepsy, their seizures get medicated, their behavior changes, and that's a whole other package of stuff. So we have a lot of moving wheels and circles, and I think we need to try to make as much as we can some sense out of it.
So the final question is around older individuals with ASD and people in their 50s and 60s. I wonder if you can briefly comment on what we know about that group.
There's very limited data. It's interesting. Pat Hallen emphasizes in her most recent chapter in the Autism Handbook that we impose kind of our own visions of what a good outcome is. To us, a good outcome is independent, self-sufficient. That's what most parents would say. That's what I would say about my kids. So we sort of assume that. And the reality is when you talk to people on the spectrum and ask them what they would like, at least the verbal ones, they would like to be not intruded upon. They might like to be left alone. They might like to follow their own, they like to feel safe. And again, they may have a somewhat different view than what we do. And it's an interesting tension and dialectic. I do know of a number of individuals who have worked out very good, their families have worked out very good situations for them, even when they're lower functioning. That being said, it's all kind of on an ad hoc basis, and nobody's looking at this, as far as I can tell, very systematically, with a handful of exceptions. And again, that Howland chapter would be a great resource. That paper by Chiang on quality of life is another great resource. makes just this point that, there's a lot of persistent issues. Some people make good accommodations, other less so. And even the more cognitively able can have residual problems.
So that's the end of our question period. Thank you very much, Dr.
Listen, thank you. I'm sorry I'm not
set
there
us on a good course for the day, and maybe someday we'll actually meet in person.
I'd love to. I'll practice my Canadianing.
Thank you.